start the recording. So just a little bit of background on this project. MPHA, as I just said, is a statewide organization, and we're recognize the importance of rural health in Minnesota. And that's something that the organization is very interested in working on. We also recognize that there's health disparities remain a persistent challenge across rural Minnesota, largely driven by structural inequities. And we wanted to explore how public health professionals saw this in their work, how it impacted their lives and their work. In order to move this forward, we had applied for and received a grant in 2024 from the Minnesota Department of Health Equity Division. And as part of this grant, we developed a survey that was sent out statewide to public health professionals, again, in the broader sense. We received a large amount of qualitative data back and have been working on analyzing this data. Fortunately for us, we collaborated with St. Kate's University, with Connie Vang and other people there. And Tatiana did her capstone project on using some of our data. Connie has been a visiting visiting clinical professor. Is that right, Connie?
Visiting instructor, practicum coordinator.
At St. Kate's, and Tatiana, as we said, just graduated. So I'm going to pass it over to them. And I think, Sarah, you're host, so you need to give them co-host so they can share their slides. And
I think I should be, I think it came earlier. Just gonna try it here.
so you can introduce yourselves more thoroughly than I did.
No problem. Just want to make sure we have our. Can everybody see that okay?
Yes.
You sure can.
Great.
Awesome. Well, take it away, Connie. Hi, everyone. My name is Tatiana Lopez, and I want to thank you again for joining us this evening. Like mentioned before, I just completed my MPH at St. Kate's. Professionally, I have experience working with the pediatric population at the University of Minnesota. So I've been able to explore in that role different fields of public health all at the same time. So I am excited to continue exploring that in my current role post-graduation, at least for a little bit of time here. I'm super excited to share my capstone research that Connie and I have worked together on for about the last 6 months. So I'm looking forward to this evening.
And then I'll just introduce myself a little bit as well. So hi, everyone. My name is Connie Sanchave. Thank you all for being here today. A little bit about myself. As a public health professional, I have a great interest in collaborating with immigrant and refugee populations, specifically with a focus on women's and children's health and accessibility. And I also have a really deep love for global health. In the next few slides here, we'll be sharing a little bit more about our research. Title Racism Exists in All the Institutions and Structures in Our Community. Rural Public Health Professionals' Identification of Structural and Systemic Health Inequities. So to begin our presentation, we'll start by discussing a few frameworks that we hold highly as researchers and professionals. In our work, we seek to be intentional and focus on using our platform to ensure that we're working to make sure that we are fairly reflective and representative of the communities and organizations in which we are collaborating with. Therefore, we want to set the framework for our discussion around social justice and health equity. So health equity is social justice in health, and it must be pursued in parallel with justice in other spheres. Health is political because power is exercised as part of a wider economic, social, and political system. In particular, I want to highlight the following 3 terms. First is distributive justice, which follows the principle that all people should be treated equally. Health justice, which focuses on access to affordable, high-quality care and ensuring all are treated with human dignity. And lastly, social justice, emphasizing access to resources and health services, regardless of identities such as race, ethnicity, citizenship, and more. Power dynamics. should not be overlooked or ignored as they determine who has the authority and power to make decisions that will impact others. This includes control and decision-making power and abilities, which can contribute to the overall outcomes. A point we want to make is that the respondents of this research are rural public health professionals, and their perspectives are reflecting on communities that they work with and may not necessarily be a part of. Therefore, it is our responsibilities as researchers and observers to acknowledge the power dynamics that exist with the shared experiences and findings. It does not lessen the value of these stories or their insights, but it is critical to be aware and reflective on the narratives. We also want to share a quote by Bell Hooks. Privilege does not have to be negative, but we have to share our resources and take direction about how to use our privilege in ways that empower those who lack it. Another aspect that we honor in our work is who we are in all of this. As we discussed, it's important to recognize the narratives we bring and that we are not separate from the work we do. Therefore, we want to share a little bit about who we are as people, our story together as classmates, the mentoring student, and now as colleagues. So I will begin by sharing a little bit about myself. I am the second oldest daughter of first generation Hmong refugees of the Secret War. I have a deep admiration for qualitative research as the Hmong community is a historically oral community. Despite really being hesitant of research as an undergraduate student, once I found my special talent for storytelling and my love for it, qualitative research really now is embedded in all of my work that I do. As a public health professional, my goal is to show up authentically and intentionally. A personal framework I am greatly fond of is Intersectionality by Dr. Kimberly Crenshaw. It is always essential to understand that there are many aspects that influence and contribute to outcomes and findings.
For me, something that has rooted my identity is being a sister, a daughter, a mother, and a first generation college student, as well as a first generation graduate student. My lived experiences have shaped me for how I view health and social justice and helped me truly grow my passion for health equity within the public health lens. My academic and professional journey has led me to wonder about stories from across borders. And before my relationship with MPHA and the Rural Health Equity Project, I really thought that this would only wander internationally, but I've learned that those borders actually are county lines or city lines as well. Connie and I have been working together, and she has been extremely influential in my journey. First, we worked together as classmates in one of our MPH courses. We were teammates and created social media campaigns together. She was on a 2-year track, and I was on a 3-year track. So, as she graduated and eventually became faculty at St. Kate's, she served as my mentor on this project. In my capstone, she was the lead researcher and first reader, guiding me through this process. So her guidance and creativity helped bring the qualitative lens to life. This was my first experience with this, so having her passion lead the way was truly beneficial for the outcomes of the project. Over the last 2 years, I've had the incredible experience of working tight-knit with MPHA, first as their student representative and now with the research opportunity. As Erica mentioned, MPHA is traced back to 1907 and primarily volunteer run to frame policy issues, present science-based information and data, and advocate for solutions. The Rural Health Equity Committee and surveys also in collaboration with the Minnesota Department of Health, Health Equity Networks, as mentioned before, and MPHA, of course, is on a continuous journey to become an anti-racist organization. For some background here, just a little further into depth, the Rural Health Equity Survey was developed with the goal of establishing connections with rural Minnesota leaders and communities to inform policy, advocacy, training, and strategic planning priorities. There were 4 main objectives in the goal, first being to establish networks and relationships with public health leaders and stakeholders in all regions of Minnesota. Second being conduct listening sessions and interviews to collect data. Third being analyze that data to create a report with recommendations to guide actions to improve rural health in Minnesota. And lastly, to disseminate the report and present findings to public health stakeholders and MPHA and LPHA members. The respondents here. Sorry. The survey, like mentioned, was open from March to May of 2024 and was distributed to local rural public health professionals. MPHA reports developing strategy aims to keep members informed, connected with rural communities, and invite them to speak out, increasing partnerships and collaborations, also promoting legislative policies to address those rural health inequities. The respondents to the survey were local public health professionals who served in several rural communities. As seen here in the figure are just different zip codes that were represented in that survey response. The survey itself included a total of 40 questions. 20 of those questions were qualitative questions. Which will be the primary focus, of course, that was throughout the project. Throughout the dissemination of the responses, we identified 3 overarching themes. First being rural public health professionals identifying the structural and systemic inequities impacting their patients, clients, and communities. Second being the challenges and barriers to delivering quality health services as a rural public health professional. And finally, the third overarching theme being insights and aspirations of rural health public health professionals in terms of supporting their work through inclusion, training, power dynamics, resources, as well as policy changes. All of these 3 combined themes aim to answer my capstone research question, which was how do rural public health professionals identify and navigate structural and systemic inequities impacting the health and outcome of their patients, clients, and communities. The decision to focus on part 1 was to reveal the current challenges that rural communities and rural public health professionals face, therefore opening the opportunity for the remaining data about the barriers to delivering quality public health services and how to address these challenges through the insight of public health professionals for future analysis. Of the 20 questions, 5 of them fall into this first theme, those being how has health equity impacted your work? In what ways do you believe racism impacts the community you work with? In what ways has structural racism impacted your work? Have other kinds of bias impacted your work? And respondents were also asked to add anything about the impacts of social determinants of health that they witness within the communities and populations that they serve.
So moving into our methods, MPHA approached the study through a mixed method approach, collecting both qualitative and quantitative data. The focus of this research only analyzes the qualitative aspects. The methodology and framework used was grounded theory through inductive analysis, in which we focus on the data really leading us to the founded categories and themes. So all analysis was manually conducted. We began organizing the data into their respective questions. So for example, here you can see we have part 1 or the overarching theme 1 with question 1, and then it lists out all our respondents' answers. Then once we organized the data, we started tagging and coding. So with this process, you go through the responses line by line and you pull out any phrases or statements that stand out. And this is again why it's important to recognize our role in the research and what insights and lenses we are using to analyze the data. Once the tagging and coding are completed, we then categorize our codes per question and then brought everything all together and then identified them into our final themes. Once we establish the themes, we then pulled the representative codes for them.
Moving on to the demographics of the respondents, there were a total of 94 individuals who responded to the survey. A few demographics that we would like to highlight include represented ethnicities, education levels, and age groups. It was determined that 81% of the respondents identified as white, which is higher than the overall state population. Over half of the respondents held a bachelor's degree or higher, and the majority of the respondents were between the ages of 35 and 44. The qualitative analysis was done by analyzing the public health professionals' answers to the health equity survey, which was distributed again early in 2024. And again, out of all of those 40 questions being qualitative answers. Through the analysis, Connie and I were able to break this down into 3 overarching themes. First theme identified was structural racism and bias. Second being accessibility to resources and services. And third being the centering the rural community. These three themes worked alongside one another to answer that original research question, which again, how do rural public health professionals identify and navigate structural and systemic inequities impacting the health outcomes of their patients, clients, and communities? Of those 3 themes that emerged, the first one here was structural racism and bias. So describe pervasive impact of structural and institutional racism on both their professional environments as well as their communities that many of them serve. Many of those respondents also did recognize that their own positionality and privilege affects those, especially white professionals, reflecting on how whiteness has shaped access to opportunities and quality care. Some of those categories that were broken down from those responses included, of course, institutionalized racism, bias, discrimination against BIPOC communities, as well as language and cultural barriers. One of the aspects of qualitative research is storytelling. From the respondents' answers, it created a story for us. Some of the quotes pulled from the analysis are used to highlight the story of structural racism and bias, and those do include, as a white person, it doesn't affect me personally, but I see the impacts daily. Colonization for Native citizens is still alive and well. Women of color's ideas are seen as not good enough to be heard. And I'm white, so I've benefited from current past and structures.
So our next theme was accessibility of resources and services. Barriers to healthcare and basic services were a dominant concern, especially regarding transportation, financial limitations, and access to culturally appropriate care. These challenges were compounded by limited provider availability, especially for populations that are historically marginalized, such as Indigenous and LGBTQIA plus individuals and community members. The categories founded were accessibility, equity, and barriers and challenges. So a few quotes for this theme include: community members with limited English proficiency are at a marked disadvantage for healthcare access, education level, and income. Healthcare was a luxury my family couldn't afford. And most of the people that I serve have family members that were affected by one of the ultimate institutional racism tools America has ever seen, and that is the American Indian boarding schools. Our final theme founded was centering the rural community. Public health professionals demonstrated a strong commitment to their communities. Many emphasized the importance of building trust, advocacy, and community engagement. Respondents noted a need to acknowledge privilege and address systemic power imbalances, particularly in leadership. The categories found were barriers to progression, communication and transparency, rural community involvement, and advocacy. Here listed are some of the quotes. I'm just going to read a few. We have to work harder to have diverse involvement in community and work to gain trust to those who are different than me. There is definitely a good old boys club mentality, especially with our elected officials and men in high power positions. And we must reach different groups of people in different ways to make sure everyone has access to the same information.
So recommendations going forward, MPHA was also able to create an initial findings report that included some key steps forward that they found, that included amplifying rural voices, advocating for equity, and improving communication. MPHA is dedicated to providing an outlet for rural stories to be told and simultaneously improving outreach to the public health professionals, since less than 9% have reported that they are being heard by decision makers. It was also our conclusion that resources and funding needed improved allocation, and MPHA has a similar conclusion that research and development should focus on and include the rural health practice. Last but not least, we are very excited to report that St. Kate's will continue analyzing the final two themes with incoming public health students and current public health students alongside Connie as well.
Yeah, and so to further elaborate, so we have recruited two more public health students, a first-year MPH student and a senior undergraduate public health student, to really continue the data analysis on the remaining overarching themes and questions. Again, those are the challenges and barriers to delivering quality health services as a rural public health professional, and insights and aspirations of rural public health professionals in terms of supporting their work through inclusion training, power dynamics, resources, and policy change. We are implementing a few more aspects to the analysis, including double analysis and a code book. So please return back in the fall to find out more updates about our findings, and then hopefully continuing to foster this conversation.
Thank you again for joining us and taking the time to be here with us tonight. As we've shared, this work is truly deeply rooted, not just in research, but by our lived experiences, values, and commitment to equity. Our hope is that these findings and conversations serve as a reminder that rural health matters and that health equity is not a destination, but a continuous journey that requires collaboration, humility, as well as courage. We look forward to continuing this work alongside you and invite you to stay connected, ask questions, and more importantly, take what you've learned today and put that into spheres of your own influence.
We also want to take the time to thank St. Catherine University's MPH program for their support and motivation. As alums of the program, the skills, knowledge, and experiences gained in the MPH program has truly allowed us to implement and apply our efforts effectively and beyond the textbooks to contribute and advocate for meaningful changes. We would like to give all the honor and glory to MPHA. The project was shared with us, and we have been so incredibly grateful and fortunate to have been able to be a part of this magnificent organization and their movement. As we know, the work of MPHA is irreplaceable, and we will continue to ask for their guidance and support as we navigate these next steps. We also want to lay our final gratitude and thank yous to the rural communities and the rural public health professionals who are out there day in, day out, dismantling health inequities and serving the communities. You truly are our eyes, voices, and aspirations. So we have listed the following discussion questions below here. Please use these questions to guide our conversations today, but please also know that we are always happy to create some space for anyone who have questions or want to contribute their thoughts or perhaps even experiences relative to the topic or the research project. The discussion questions we have proposed today are: how can public health professionals working in positions of privilege, for example, through race, education, urban settings, responsibly use their platform to elevate rural and underrepresented voices and health equity work? What are some practical ways rural public health professionals and the systems that support them can address structural racism and bias in their communities, given the constraints they often face? And lastly, how do we move this work and our efforts beyond public health professionals and include the local rural communities? So again, we thank you and we're looking forward to the discussion.
Thank you. That was a wonderful presentation and a lot of information to think about. And you did a great job at looking at the information that they provided. As you said, there was a lot of comments and information. And that was one of the things that surprised me looking at it, is how much people expressed and they wrote, which to me also said that there's a gap of where they can share their thoughts and their voices. And so maybe that's sort of starting us off on one of the questions is that I think it's our responsibility to find spaces to allow rural public health practitioners and professionals to be able to share their voice and hear them and then bring that forward in order to change some of the way the work is done. So now we'll open it up and you could either raise a hand or just share comments, thoughts.
I'd like to hear from Tatiana or Connie on those one of those specific questions. And what you think, and then maybe it gives us some of our folks in the call who can only, some of them can only respond via chat. Gives people some time to either type something up or come off mute when after you say something. So maybe the first question, what do you think?
Yeah, so I am in a clinic. We are in Minneapolis. We get tons of referrals from all over the state, and sometimes we are crossing borders into North Dakota and Wisconsin as well, where pediatric dental care is just not accessible. So we have been trying to use our platform and our name to really get resources either reallocated through the use of dental students, finding ways to partner with other non-governmental organizations to provide like group transit if there is, a group of kiddos coming in from East Grand Forks and we all need to get to Minneapolis. We're trying to reallocate some of those resources that are readily accessible to us so that we can show policymakers and higher ups that other resources are needed so that these kiddos and these families don't need to go so far for quality care and accessible care in terms of the specialist, the insurance coverage, the place where the work can all be done in one go around. So that's what I've noticed more and more. My eyes have been peeled as I've been getting incoming referrals and looking at the lack of care in rural areas. So ultimately, we have to use our position as being in the metro to really get the word out and get the resources out.
Yeah, thanks for kind of flipping around and giving us the chance to answer this question. So thank you. I, I guess I can kind of address like a few points within all these questions. So something I often been telling my students since I've been teaching at St. Kate's is I think often when we come into public health, we feel that, we see a lot of the health disparities and we kind of feel this need to fix everything or go out there and like save the world, right? We really want to help people. And I often tell them it takes teamwork, right? We cannot be everywhere all at once. And so really knowing who you are, leaning into what interests you and your position in all of this is a very powerful stance to have. And so I try to navigate my work in public health in such a manner. And so when I'm thinking about these questions and I'm reflecting on my role in this research, I strongly feel like I am a qualitative research, and the way that I carry out my research is that I want to create the space for the people to share their expertise. And so it's interesting how, sometimes our first thought is like the interventions or how do we implement this, but I find that it's sometimes not as often that we're actually going into the communities and asking them about it is that they seem that may work for them, right? Um, like I said, it's sometimes beyond the textbook and really getting back into the community. And I think for someone like myself who has the privilege of having had exposure to higher education and also live in urban settings, really like familiarizing myself back to working and collaborating with the rural community. And so really hearing what their experiences are, not just from the public health professionals that are working with them, but them themselves. Because again, what we know is what we perceive, and sometimes, you know, we may have these things that we want to address, but at the same time, are we really asking those community what it is that is those challenges and what are those barriers? And so that's kind of how I would like to use my platform, is to continue giving people the platform to share their experiences and their stories, and then really amplify those stories to the space and the stages that they need to be at.